Well, we have a fantastic panel here to start the day off. We're going to go over some of the legal framework, the international legal framework for Medicare for All, and how it is a human right. And there is also a complaint being worked on with the UN to basically say that the United States has violated their obligation to provide a basic human right in the form of healthcare. So I'm very excited to get into things today. For those who may not know me, I'm Luke Parcher. I'm a volunteer with Real Progressives and Real Progress in Action. I'm on our leadership team. I'm a student activist and political commentator, and I am just thrilled, honored, and humbled to be a part of this summit this weekend. Thanks to everybody for tuning in today and the other days. And with that, we will go ahead and bring in our panelists so that I can introduce who we're going to be talking to today. We have Martha Schmidt. Martha is a human rights expert and activist, co-chair of the Human Rights Framework Project, a board member of Center of World Indigenous Studies, retired labor and equal employment attorney. She is a former professor of human rights, political economy, international relations, and public policy, past union organizer, from Wisconsin and with the University of Washington. We also have Mary Gerisch. Mary is currently living in Vermont. Mary has been a healthcare and human rights advocate for many years on a state, national, and international level. Mary was the co-chair of the United States Human Rights Network's Universal Periodic Review Task Force for Geneva, and a nationwide advocate, and also the co-chair for the International Covenant and on Civil and Political Rights in the same arena for the past 10 years. I want to thank both of you so much for taking the time to be here today.
Thank you.
Thank you.
And just quickly for the audience, the way that we're going to format this, we have a few presentations to bring you. And once the presentations are over, we're going to do a Q&A session. So while our panelists here are presenting, if you have any questions that come to mind, please put them in the chat section, and we will have some people behind the scenes checking for questions to ask during the Q&A session. So we're going to start with Martha on explaining the legal right to healthcare. If we want to go ahead and dive into that first presentation.
So this is going to be about the basics of the international human right to healthcare. I'm calling it Healthcare Human Right to Healthcare 101. Next. So the first thing to understand is that a human rights approach is very accessible and can be used by everyone. So this is not just for lawyers. And I want to tell you that international law protects the right to health and includes the right to health care. The right to health is a broad kind of human right. It encompasses social indicators of health, such as having clean air and water, uncontaminated physical environments, affordable and decent housing, sufficient income, and other things. And the cross-cultural research shows that income inequality itself results in inferior health outcomes, such as higher morbidity and mortality. The experience of the pandemic and the problems of our global economy really indicate the need for internationalism here, and for us to reject imperialism and adopt a holistic analysis of the human right to health care. We need to work with everybody who are our allies. The right to health care is a legal duty, and it's owed by a state or a country, the United States, at the national level to all its residents. Next. Now let's just think about what we have here. It's the opposite of the human right to health care. Our whole society is dominated by neoliberalism, and particularly our healthcare system. For example, neoliberal ideas include the following: that market society is natural and a necessary state of humankind, that humans are consumers, not citizens. So if there are no citizens, of course, there are no human rights and no right to health care. Another neoliberal idea is that the inequality of economic resources is just a natural byproduct of capitalism. And inequality is even good because it motivates progress. Then there's the idea that freedom is a negative idea, a negative state, that it's freedom from. And it rests on the idea that self-governed individuals exercise some kind of rational self-interest by buying health care. So, for example, buying insurance, and of course, through markets. And every single problem of healthcare systems has a market solution in our society. Also, another part of neoliberal philosophy is that we need to have a strong state. You might read that as authoritarian, to tamp down the pathologies of democracy. This is a core idea of neoliberalism. So our groups asking for healthcare as a human right are considered aberrations and need to be put down. Next. Our movement's mission is to stop this kind of American exceptionalism in healthcare, join the rest of the world, and achieve the human right to healthcare. And let me just say that the US is exceptional. It's exceptionally bad. It's number one for spending on healthcare. It's about 20% now of our GDP, $4.1 trillion in 2020. But we have the worst outcomes in the entire OECD. That's the organization of so-called advanced capitalist countries. We have the worst outcomes for life expectancy at birth, for infant mortality, for maternal mortality. We have the most suicides. Then there's the personal costs of this. 2/3 of our bankruptcies are related to health costs. There's also the incredible medical debt that people have to live with. And people's lives are in ruins, literally, because of the cost of healthcare and having to make choices that no one should have to make. There's also socially the increased inequality as a result of this privatized system. And as a human rights activist, I really have to say that it's especially horrible that what this does, the denial and the privatization of healthcare, negates the entire right to an adequate standard of living, which is a right separate from the right to healthcare and something that hardly anybody even knows about. And it's actually in the Universal Declaration of Human Rights, which goes back to 1948. The other exceptional thing about the US is the profits for the medical industrial complex. 2022 was the highest in world history. And obviously, this system benefits pharmaceutical, insurance, hospital, nursing home companies, and their billionaire CEOs. Next. So let's talk about how we can bring down this private for-profit health industry by using the human rights framework and particularly focusing on the human right to health care. The human rights framework gives us a tool, a legal tool. It's based on international law, and it allows people to participate and claim their dignity. Human rights are actually internationally, legally recognized and based on specific principles of law, sometimes we call them elements. This is something that applies to every single country. So the US just is one country to which these standards apply. This evidence, though, of violations of these principles can be used to make our demands, and we can use this to hold our political leaders accountable. Human rights are considered to be universal, interdependent, and indivisible. This means that the rights apply to everyone, that the rights themselves are interdependent. They have to be all protected, and they have a bearing. Like, for example, the right to healthcare has a bearing on the right to housing, and the opposite. And they're indivisible, that you can't take parts away of the human rights that exist and consider that that is an acceptable public policy. What we see in the US is the weaponizing of human rights. We see that that politicians selectively prefer certain rights. For example, free association. They also misinterpret what a human right is. And there are hierarchies given to rights. Just one relating to healthcare is something that the Supreme Court has done. It's given priority to the religion of corporation owners over women workers' reproductive health care. That's the Hobby Lobby case, and I'm sure some of you know about it. Next. So let's focus in on what these principles are. These are the essential principles of the right to health care. First, universal access to all health goods, facilities, and services. Absolutely everybody in and nobody out. And that means universal, not one state getting health care and the rest of the states not getting health care. It's a national project to have a human right. Secondly, there's a requirement that a state have available health infrastructure and services. I'm sure everybody living through the pandemic understands this one really well now. Another principle is the principle of acceptable and dignified care, equal and non-discriminatory care, the highest attainable quality of both physical and mental health, participation in the decisions about your health. This is as an individual or their social aspects. I'm going to talk about each of these a little bit more. Then there's a requirement to have transparency, and that relates to information for patients, knowledge about the healthcare system, information about physicians. And then finally, of course, every human right requires accountability and requires some kind of mechanism for holding those who have control, political control, economic control, accountable to the people whom they're supposed to serve. Next. I'm not going to go into detail over these international law sources, and this information will be available and is available generally, but I just want to say a little bit about these sources. These are treaties. Some of them are declarations, and they start in 1945 with the UN Charter, which actually had a fair amount of language about the purpose of the international system to uphold human rights and dignity. There is also another early attempt to protect the right to health, and that's in the World Health Organization's constitution in its preamble, which actually is from 1946, and that called for the highest attainable standard of physical and mental health. So that concept is very old in terms of the development of international law. The main sources which are listed here are the Universal Declaration of Human Rights, Article 25, which protects the right to health and an adequate standard of living, housing, water, and income security. Then the International Covenant on Civil and Political Rights has one article that addresses the right to life, which of course is closely related to the right to health. The main treaties that the US has actually ratified, that one, and the Convention on the Elimination of All Forms of Racial Discrimination also specifically mention life and health. The elimination of all forms of racial discrimination focuses on health and some other social and economic rights. Then we have the Convention on the Elimination of Forms of Discrimination Against Women, which of course addresses women's particular health needs. The Convention on the Rights of the Child, the Convention on, I should say, the Covenant on Economic, Social, and Cultural Rights reframes what is in the Universal Declaration, but focuses very specifically on healthcare. And then we have some other more recent attempts to protect the right to health in the what's called the Convention on the Rights of Persons with Disabilities, protection of the Migrant Workers Convention, which is doesn't give a real full right to health only for emergency medical care, and the most recent Universal Declaration on the Rights of Indigenous Peoples, which attempts to address some of the cultural and other factors that are left out of some of the rest of the healthcare treaties and declarations. Next. So let's just focus on universal access, which is one of our core principles in the March for Medicare for All and National Single Payer and other groups. So this is so key, especially given our experience with the pandemic. There's 4 parts to the idea of universal access. The first is the universality principle. So this defines residence broadly. So residence in a country is not like residence in a state. It's much broader concept. And for example, in the US, it would include Puerto Rico, which is basically a colony of the US, but people are residents. They have a legal status in the US. But it also includes people who don't have documents, but who are residing in the US jurisdiction. So this idea means that if we hold the US up to international standards for universality, it's woefully inadequate because it leaves out so many immigrants and migrants who are residents. Another part of this universal access principle is affordability. And that means free at the point of access. There aren't any cost barriers. It means also a system that's financed fairly and efficiently and according to progressive taxation. So a single payer finance system like Medicare would meet that affordability standard as long as all the cost barriers are removed, such as co-pays and all the rest of it, premiums. And then it has to be comprehensive. Universal access means that you get everything, the full suite, as they say, of services, goods, and facilities. So everybody has access instead of what we have now, where you have, some silver, gold, platinum, bronze, whatever, brass, color of metal kind of care. Then it's based on universal access includes equity. And equity is a hard concept in the United States. And I'll talk about that more, and I hope we have more discussion on this. But equity means equal access, but it means according to need. So some people need more. So those services, goods, and facilities would be more used by some people. And that's an equitable principle going way back into English common law. And it's really, it goes along with equality. So if you have an equitable system, it systematically addresses the group disparities that, for example, disparities from the existing racism that we deal with in the United States. Next. Another principle is that of availability. So this means that the state invests in and maintains the necessary infrastructure for the healthcare system, and that the facilities and the services and the providers are located near where people live, and that there's not neglect of people in poorer neighborhoods or rural areas. What a system does that meets the availability standard is to have a mechanism such as an incentive to ensure that health services exist in those areas. Also, another problem that's really severe in the US is the absence of primary care physicians and nurses. Most nurses are migrants because we don't allow enough nurses to be trained. So a single payer system, a system that honors the principle of availability, then invests in training, education, and it regulates so that all of those parts of the system are available. Next. Another principle is one of acceptable and dignified care. And I noticed this came up a lot in the workshop, the slideshows yesterday on racism in healthcare. Care is offered freely. It's in keeping with the dignity of each individual, including elders at the ends of their lives and people with disabilities. No one is treated as subhuman or undeserving. Care is also culturally appropriate. It takes into account the nutritional preferences and needs and healing modalities of diverse populations and indigenous peoples. Care is offered, not forced, and individuals, including incarcerated people, are not subject to experimentation. Next. This gets into the area of, I think relates back to the question of equity, but is a really cornerstone part of a system that meets human rights standards, the principle of equal and non-discriminatory care. And obviously those aren't exactly the same things because you might have non-discrimination, but not equality. So it's much more complicated. But both equal and non-discriminatory health care are measured by access as well as outcomes. So no more of this, equal access business, but the outcomes are totally different. That's not acceptable as a human right. Also, affirmative measures can and should be used to address structural racism and other systemic forms of discrimination. So, basically what is known as affirmative action in the US is something that the international legal system embraces wholeheartedly to address disparities. The other thing that's, I think, useful to know for people in the US is that that international human rights law actually prohibits more kinds of discrimination than US law. It's broader and it has the capacity to be even broader than what we have. It includes political or other opinion. It includes property, birth, social origin, and it has what is really useful, an other status category, so that can protect people in groups who may be excluded under national laws. And it includes possible discrimination that may arise in the future. So it has a lot of potential for citizen action. Next, getting into the principle of highest attainable quality of physical and mental health. This, as I mentioned earlier, is an old standard, international law standard that comes from or was first in the World Health Organization Constitution. It's also mentioned in the Millennium Development Goals, which is an attempt globally to adopt development goals for the entire world. And I bring this up here because the US, as a so-called development country, doesn't meet the Millennium Development Goals, which were intended to apply especially to countries that are poor and don't have the same economic resources. So a state, regardless of its level of economic development, is expected to provide each person with a minimum core of essential services. So we're talking about something that is longstanding here, and that was expected even when these treaties were signed by countries that didn't have a lot of resources, and when they ratified those, they were still committed to doing that. But the US has not caught up with the rest of the world. And it requires that states use their maximum available resources. But the US has not, for example, offered free primary care for everyone, which is a minimum core of essential services and part of the Millennium Development Goals. So that's a problem. It also, this idea of the highest attainable quality of physical and mental health requires investment in education, investment in facilities to meet safety and other standards. It requires adequate payment for healthcare providers and of course, regulation, including of pharmaceuticals. Next. Then there are three other principles that are part of the basic elements of the right to healthcare. One is participation. And this is a civil right. It recognizes an individual's power to make decisions. There's also another part of participation, which is a social right. It's a democratic process that people have a right to make policy decisions about the healthcare system. It should not be the province of corporate boards. The transparency principle also is a civil right. It rests on the idea of free expression, speaking, disseminating, receiving information, and while respecting individual autonomy and privacy. And this, of course, as a social right, when we look at the whole healthcare system, involves the rights to associate and assemble. And finally, the accountability principle, which I mentioned earlier, it's based on civil rights to due process of law and having a meaningful remedy, so that when the healthcare system fails individuals, they can sue. They can get some kind of remedy. Next. So I want to talk just briefly about the affordability principle and the weaponization of human rights. I think one of the things that we need to do as, activists using human rights is to beware of how those who do not support human rights weaponize human rights. And I'm just going to use the example of the Patient Protection and Affordable Care Act, because that, of course, as you know, includes the word affordable, which is a part of universal access. So in my view, what happened was that was an attempt to co-opt this principle. It grossly manipulates the idea of affordable. Affordable is in the international legal view is affordable from the standpoint of the individual, not from some corporate enterprise trying to get the maximum amount of profit out of individual payments. Means testing is one of the parts of our system, and means testing means a real problem for human rights because it can never be equal with a means tested system because it ranks people according to their ability to pay. And although some people may consider that wealthy people should pay more, it actually is contrary to the idea of a human right, which rests on the idea that all citizens are equal and you have an equal system. And the problem with this from a human rights standpoint is that you have certain categories of people who are worthy and certain categories of people who are less worthy. So it goes against the idea of having a right that is shared by everyone. There's also the issue of how people are divided and conquered with this kind of notion of means testing. It really does also end up dividing people on by the use of charity. And I just mentioned, there's a couple of things that I think are particularly problematic with the charity part of the affordability. One is, that people are supposed to beg pharmaceutical companies to pay for their drugs or give them some special deal if they can't afford to pay, right? That's the solution. Or let's see, there's also GoFundMe, right? That people are supposed to individually raise money for their healthcare needs. But basically what you're talking about is begging rather than having a right. And this is really important, I think, to understand about human rights in general, that all human rights are based on equity and equality, and all human beings are deserving. So if you start off with a system that doesn't accept those principles and work from those, you end up with, among other things, our healthcare system. Next. Then there are actually principles that are specifically applicable to financing the right to healthcare. So this is, I think, germane to the whole issue of single-payer financing, because these can be used, and in some ways they're not maybe totally consonant with modern monetary theory, but they're still things that we can use. So the principles require that the healthcare system be financed adequately, equitably, and sustainably. So it seems to me that the way forward is for us to really think about single-payer financing in relation to the problem of privatization, which further commodifies our healthcare. The idea that funding for health is a public good and should not be for profit, that we need to have a financing system that provides equity for the most vulnerable, the most people who have the greatest need, not the opposite, which is what we've got. That we need to have a healthcare system that reduces income and wealth inequality, not increases it, which is what we have. And then there's an internationalist principle here, which actually is related to the US commitment and other countries' commitment in the UN Charter. And that is a duty to cooperate with other countries to address global health problems, including the COVID pandemic. And this is this duty to cooperate is something that needs to be incorporated into the healthcare system and the financing. And obviously, this relates very closely to climate disruption, climate crisis. Next. So looking at adequacy of financing, again, the U.S. is required to commit the maximum available resources to fund the right to health care. So everybody knows, I think, that we spend the most of any country, but we have misallocation and underfunding, even though we spend a lot of money, 4.1 trillion, I believe, in the last year. For example, budgets misallocate funding in order to guarantee private profits, not healthcare, such as to Part C Medicare Advantage. I like to call it disadvantage, not Part B Medicare, improving Part B Medicare. There's also underfunding, which reinforces social inequality. For example, the Indian Health Service infrastructure is neglected. It gets lower per capita funding and less secure funding than either Medicare or Medicaid. Of course, the adequacy issue is completely absent from the area of women's reproductive health care, and it's pretty much ignored as far as parity for mental health care. And as I said before, immigrants are grossly underserved and excluded from health care. So it's not adequate in some ways, even though lots of money is spent. Next. Equitable financing, again, it's related to some of the funding sources. So, for example, we have funding from general taxes relying on income tax and Social Security tax. And income tax is more progressive than Social Security tax, which taxes people on the first dollar they earn. So you can see the kind of burden that exists. There's also, of course, the absence of taxes from capital sources. And then there was the corporate tax reduction by act of Congress in 2017 that reduced the corporate tax rate from 35 to 21%. So that shifts the burden onto the taxes from these other sources, which of course affect your ordinary working people. And then, of course, the most horrible thing of all, which we know so well, is the reliance on user fees, what they call user fees. That also is a total neoliberal concept, that because it doesn't want to recognize common goods, right? You have user fees, and it doesn't matter what happens to users who don't have a lot of wealth, right? But we have, premiums, deductibles, co-payments, and I'll just specifically mention the burden on the individuals in the, lowest three income quintiles. And people are just so hard hit by the user fees. And I can speak for myself as a Medicare person too. Anyway, okay, next, the other principle is sustainable financing. So this is a question of what it would look like, really, because we don't have it. What would sustainable financing look like? And first of all, this gets also back to some of the foolish experiments with trying to get state-based healthcare, and that is that only the federal government has the ability to fund for the long term for everyone, and to have a secure form of funding for every single person in the jurisdiction. Also, there needs to be priority, of course, of healthcare financing. So that is a political issue, and it needs to be nationally secure so that it doesn't get cut back. And we see that some of those issues cropping up elsewhere in the world, and as where you don't have good law and strong, strong movements to defend healthcare, you end up with these kinds of problems. But I do think that if you have a real commitment, a priority for healthcare as a human right in your legal, in your law, that you're going to be in a better place. Obviously, single payer financing is the most sustainable because you get a unified system, you get economies of scale, you get removal of profits, or we need removal of profits and the profit incentives, which would reduce costs clearly, and reverse the commodification of health. I have to say again that profit based on the denial of care is just totally the opposite of the human right to health. So, and the impact of having sustainable financing, a national single payer system, it would remove healthcare costs, the burden of those, and it could have such profound impact on especially people of lower incomes, but it would also benefit everyone. It would increase the standard of living. It would reduce the wealth and income disparities. It would reduce racial and gender inequality. It would reduce morbidity and mortality. It really could have a profound impact on our society. Next. Done.
All right. Hey, I do want to ask, we're starting to get some great questions here. I want to encourage everybody to put their questions in the chat box if they're wanting to ask the panelists any questions. Before we move to Mary's presentation, there was a clarifying question that I thought it would be valuable to get out of the way here, Martha.
Sure.
Can you just, for a lot of viewers, they probably do already know the answer to this, but can you just give a brief definition of means testing for those who might not understand what that means?
Yes. So a means testing, an example is Medicaid, and which of course pre-existed the Patient Protection and Affordable Care Act, so-called. But you have to under the new provision at 200% of the poverty line allows you to get subsidies. So it basically you have to prove what your income is, in order to get benefits. And then the other corollary of that, of course, is if your income goes up a little bit, you get cut off.
Yeah.
Mm-hmm.
And so what you have is a bunch, and this is our whole society, whether it's health, healthcare is intricately connected to all kinds of welfare used in a broad term. And so if people do a little better, they basically start losing things that allowed them to do a little better. So that's what means testing is. It's just poisonous to having a society based on rights.
Yeah. I mean, imagine a system where you make an extra few $1,000s a year and you end up worse off for making a few extra $1,000s a year. It's really insane. I mean, the idea is
and the dignity issue too of having to report, because now in many states, it's like they've got people corralled into reporting monthly. Now, so many people have irregular income from month to month. And doing that that's just like horrifying and actually makes people in a permanent state of anxiety. And then if you earn a little bit more and then you don't get health care, and something else goes wrong. So that's what I mean about lives in ruins, because that's the reality for a whole lot of people in the US of the way the healthcare system works.
Yeah, I appreciate the clarification there. And we're going to move on here to Mary's presentation. She's going to talk a bit about, you said you wanted to kind of drive home the concept of equity. Mary is going to go into some of that stuff, how healthcare is a right and how it's in the interest of the public good. If we can go ahead and get Mary's slides up on the screen and begin her presentation.
Hi, thanks everybody. So even the last 2 years during a pandemic, the only way people could get health care here in the United States is if they had money. And so next we're going to see, we're going to talk more about that and whether healthcare is really a right or not. I know you're all saying, well, of course, healthcare is a right. We know that. So I'd like to tell you a little story about when we were in Geneva for the hearings on the International Covenant on Civil and Political Rights. And we were giving a presentation and talking about healthcare and how it impacts marginalized peoples more. And one of our own advocates from this country, who is really a wonderful human rights advocate, said to me, or said to the group, oh, well, the Affordable Care Act has improved people's rights. And somebody else said, yeah. And I said, wait, are we talking about health care or are we talking about health insurance? Because the Affordable Care Act is all about health insurance. We have been so brainwashed in this country that as soon as somebody says health care, there's this little equal sign in our brain that talks about insurance. And so we really need to get rid of that because healthcare is an actual right, as Marty has pointed out. And in fact, historically, the Declaration of Human Rights actually arose from a second Bill of Rights that Roosevelt was working on before he passed away. And his widow, Eleanor, is the one that brought it to the UN. So this was originally this was a US idea. If we want to talk about US exceptionalism, it makes it even more absurd that we don't honor it. The other thing is that the International Covenant on Civil and Political Rights that Marty was talking about, and she mentioned it's a treaty. Now, you may all know this, but before I started doing work internationally, I did not. When we say treaty, we're not talking about, it's not like a derivation of it's an actual treaty. Our government voted yes and then ratified it. And it is a treaty the same as the one that stopped our war with Japan. What would happen if somebody violated the treaties that stopped the wars? There would be public outcry all over the place. Well, this is a treaty. So we need to name healthcare as a right and inform each other about it. And if you're human, you have the right. That's all. There's no other qualifications, nothing economic, nothing ethnic. You have that right. And if we don't keep convincing each other and our friends that it is an actual right, just like anything in the Bill of Rights, okay, then we're not going to be able to claim it that way. We're going to keep talking about insurance programs and, cheaper insurance and cheaper copay. That's not healthcare. So let's take a closer look at this as we move on. So our government has an obligation, as we know, to protect and fulfill our rights and needs. And lately, well, not just lately, for many decades, we've had the pull yourselves up by the bootstraps mentality, right? That's not going to work for someone who doesn't wear boots. And there are a lot of people in this country that are in that situation. So it's ironic too, because again, at one of the last Geneva things, we had a healthcare panel and we had all the people from the Secretary of State, and even a couple of people from the Pentagon. They were high level because that president was cooperating with the UN. And they were talking about healthcare, and all they talked about was the Affordable Care Act. And so several of us said, wait, and they called these healthcare measures that the US has taken. They did that intentionally because they know if they called it a right, we would know they were violating our rights. So they called it a measure, right? Oh, yes, healthcare measures are increasing in the US. And the international community is like, oh, really? And those of us from the US are going, excuse me, why are you using the word measure? Healthcare is a right. And this Insurance Act has nothing to do with our right to health care, not health insurance. And so that they, of course, wouldn't answer the question, but it did make the point to everyone who was in the audience. So healthcare is a right, so therefore it's a public good. And it's not happening because we still perceive ourselves as consumers instead of rights holders. And that's why you're going to hear me talk endlessly about naming it as a human right and claiming it as a human right. And I know it sounds like, oh, yeah, we know Mary. But talk to some of your friends. Talk to some of your associates. Just find out whether the Affordable Care Act or anything like that comes into play, because then you're not talking about healthcare and the right to healthcare. So let's move on. And so we talked a little bit about this, but if healthcare is a right, then it needs to be considered a public good. And the government needs to provide the resources to prioritize that, not waste them or distribute them inequitably. And privatization, which is what the pharmacies, medical equipment suppliers, and insurance companies have done to health care, to turn it around from a care system to an insurance system or a profit system, profiting on our suffering, is not the way we finance rights and public goods. So we'll move on. And this is self-explanatory. Even if you are on Medicare, there are things that aren't covered. Even if you have the best insurance, there are things that aren't covered. And I know this isn't storytelling time, but someone I know from Vermont, when I was writing an article that did tell stories, and I'll give you the brief version, his wife had terminal cancer, and it was an unusual kind. And if the insurance company, and they had the best insurance coverage available, okay, if the insurance company would pay for this particular medication that's very not often used because it's rare, then she might be able to live. Well, their doctor and their hospitals went to bat immediately, bombarding the insurance company with letters saying this is necessary for her life. It was deny. You know, insurance companies, you have to get to the very top. You have to go through all these denials before you get someone who will actually even consider it. Well, what happened was that about 3 days after she died, on his front porch was a package of the medicine that had finally been approved. That is not health care as a right. So let's move on and talk about how we might be able to treat it. Yeah, I'm sure most of you have seen this portrayal of equity and equality before. And equality, by the way, in terms of international law, is a lot different than what we view a lot of kinds of equality as Marty already pointed out. So if we give everybody the same box to see over the fence, the bigger people can see, the little one can't see anything. If we give everybody a box that will raise them tall enough to see over the fence, then that's great. That accomplishes our goal. In reality, what we have is we have an actual chasm between people who can afford healthcare and people who can't get or die from lack of healthcare or pharmaceuticals or medical goods. That's why we need to keep calling it a right, and we need to keep talking about equity. And if we move on, we can see that there isn't a healthcare system in the United States. We don't have one, period. End of story. We need to establish one because insurance is not equitable and it's not a public good, and it only creates profit. So moving along, we're looking here at a bunch of different public goods. Okay, we got ambulances, fire trucks, school buses, and education, food stamp programs. So let's just think about this. Streetlights, another one. So if I call an ambulance because I'm having a heart attack and they said, let me check and see if your insurance is paid first, and then I died waiting for them to get here, that's not healthcare, but that's essentially what we have when we don't treat it as a public good. Same thing with the fire department. Are they going to not put out my fire because I can't pay them or I don't pay real estate taxes? No, of course not. It's funded from public funds as a public good. Education. Are they going to tell me I can't go to school? You can't go to school because your parents aren't working right now? No, they're not allowed to. Food stamps. And I know because there's been a lot of litigation on food stamps and certain states not letting people have them, which is clearly a violation of those persons' rights. And that has been upheld. And so obviously that comes as a public good. So when we're thinking about public goods, let's move on. And again, go back, and I'm sorry, I know I already said this, but again, go back to health insurance not being health care, because the latter of those, health care, is a public good. So what we have right now is a system where you pay monthly premiums to a for-profit company. Even if you're on Medicare like I am and have a supplement, you still pay monthly premiums to a for-profit company. You also pay at the point of service. There's a copay. It's like I called my doctor's office once and I said, I know I have an ear infection. They said, all right, the copay is $45. And I said, well, it's the end of the month. I don't get my Social Security till the 3rd. They said, then go to the emergency room. Do you know how much that cost? So I'm just saying that is not a public good. And annual deductibles, we all know, $10,000 isn't probably the maximum. I think there's some people have $15,000 and $20,000 maximums on their deductibles. So let's go ahead and think about the people that don't have any insurance because they can't afford all those things we just talked about. So, and these are probably conservative estimates because these are taken from mostly pre-COVID, or at least a little ways into COVID, where 30 million people had no insurance and 71 million people are underinsured. So these are the people like the friend I just described who lost his wife, who paid the insurance premiums, paid the deductibles, and still couldn't get the care she needed because there was no equity in the system. That care wasn't an approved drug by the insurance companies. And 2, it wasn't a public good. So we need to get rid of all of this and go with public good. So moving on, we don't have any cost controls on those insurance companies. We really need to get rid of them entirely. The premiums go up every single year. Do you really think it's because healthcare costs are going up? Well, yes, They probably are, because there's no control on the pharmaceutical industry. People pay more now for insulin than they did years ago, based on the same level of income that was appropriate at the time. Why is that? Insulin is a drug that has been around forever, and yet it's gotten more and more expensive. Why? Because more and more people need it, and the pharmaceutical companies can make more and more money. So, hey, why not? So, and then when we have insurance, people that go to work take home less money out of their paychecks because the employers deduct their payments. Okay. So even with a good job, depending on what insurance company your employer has, you're losing money, and then you got all the other stuff to pay. There are a lot of people who choose between healthcare and rent and food. And the people that suffer the most are those who are marginalized for any number of reasons. And moving forward, what we need to do is we need to remember that healthcare has to be accessible, as in free, at the point of care for everyone. And this includes all healthcare. I'm not just talking about the things that insurance companies cover. Preventative care, yes. Care for any medical condition, including mental health. Equity isn't about, I get the same as you get, as we saw on the earlier slide. It's about, I get what I need to live a dignified life and a healthy life. And that's not going to be the same as what Marty needs or what Luke needs. We all have individual needs, and equity has to take that into account, including long-term care and including the ability to stay well so that you can buy food and pay rent and continue to be well. And that's also called living a life of dignity, which is really what human rights is all about. So let's move forward and talk about some populations that can't freely access health care. African Americans, Indigenous peoples, my peoples. We've seen terrible stuff on the reservations, particularly during the pandemic, but always. Differently abled people. They can't, so many folks can't even, our systems are so difficult to navigate on the internet or on the telephone or wherever, that even if you could afford it and you're differently abled, it's going to be difficult. Say you're supposed to use a computer to sign up for your insurance. What if you don't have one? Or what if you can't see one? Or what if your fingers can't type on one? It's crazy. LGBTQA plus folks. Nope. I'm sorry. No hormone therapy for you. I'm sorry. And if we had equity, that would be someone's individual need. And equity in our health care system would make sure that everybody got what they needed. Women, particularly reproductive rights, one way or the other, whether they don't want to have the baby because they can't care for it or because of a health condition, or whether they do want to have a baby, but they've been involuntarily sterilized because of their differing ability or their ethnicity. So either way, it's got to stop. Immigrants, they can't get anything because they'll be reported and they'll be shipped out of the country and they'll lose their job and probably their families. And any kind of economically disadvantaged worker or non-worker experiences these same problems. So let's move on and think about how the pandemic has highlighted this problem. Racial inequities, if you look at the figures for the people that are getting sick and dying, Black and African American people, indigenous people, other peoples of colors experience this much more severely than the general population. And economic inequities are evident because those who have a high income, if you look at the figures, aren't dying or getting sick as much at the same rate as those who are poor. And so, and immigrants, of course, suffering at a higher rate than non-immigrants. So that's something in the last 2 years during this pandemic that should highlight on the next slide why we need to use the right for healthcare. It needs to be a public good. It needs to be equitable, so everybody gets what they need. If we don't say this is a right, just like our right to vote, and I know a lot of rights are in question right now, but I'm just saying, it certainly can't hurt if we use the word right with each other, with our friends, when we're speaking, and demand that because it's a right, it has to be a public good and it has to be administered with equity. And Marty's next presentation is going to be how we can let the world know that our right to healthcare in the US doesn't exist. And we can help to claim that. Thank you.
Thank you so much, Mary. And just before we get to Marty's second presentation here, I just wanted to underscore a couple of points. First of all, you made the bootstrap point. We had a panel yesterday about how the profit incentive is really what creates a perverse incentive for the healthcare system to start with. And I just want to make sure the audience understands. The bootstrap thing was originally a literal joke, right? You can't imagine you're laying on the floor trying to pull yourself up by your bootstraps. I mean, it was literally a joke, and then it became all of, the rhetoric on the libertarian sort of side of things. And I also just wanted to share a very quick anecdote. I shared this on Friday at one of the panels, but I think some people don't understand the reverberating effects of Medicare for All in a way that they should. I had the privilege of hearing from somebody who's involved with the union in Las Vegas that covers a lot of the hotel and restaurant workers and things on the Strip. And they expressed to me how much of their resources went to negotiating a decent healthcare system. And how, if those resources were able to be placed on, we could be getting you better compensation, better workplace treatment, more time off, things like that. And I just want to underscore for the audience some of the reverberating effects for working class people that would come from a Medicare for All system. So with that, we'll go ahead and move on to Marty's second presentation here. She's going to detail the complaint to the UN and other things as well. If we can go ahead and throw that second show up on the screen there.
Yeah, and I just wanted to echo what you just said about negotiating union contracts, having been involved in that, where you spend all your time trying to get better health care and the wages never go up because the employer is always paying more and more for health care. So that's a good reason why we need health care as a human right in a national system.
Yeah,
so
absolutely.
What we're going to do is what we're doing now, the March for Medicare for All and hopefully allies, is to take the human rights approach and use it. We're going to file a complaint with the UN Human Rights Council on the right to health care. So this is a little guide that I've developed, and actually I have a few updates to some of these points. So next. So first, what the heck is this? What is this human rights complaint to the UN, and who can file it, and how is it done? So the UN, the United Nations, has a number of parts, agencies, and associated components. But this is going to be about one of those parts of the UN system. So an individual or a group or a non-governmental organization or some combination of these can file a human rights complaint. So as you see, that's fairly broad. It can be filed against any member state of the United Nations, which the U.S. is one of. And as you know, it's a permanent member of the Security Council. The U.S. was a founding member of the UN. And this complaint will be filed with the UN Human Rights Council. So that's the sub organization of the United Nations system that we're talking about. This is what we have to do. We have to show that there's a consistent pattern of gross human rights violations in order to file a complaint. So what this means is somewhat technical, but I think applicable to the right to health, the right to health care. First of all, the gross violations of human rights require a severity of offenses. So severity could include loss of life, disabling illnesses, shorter lifespan, failure to provide care. All of these are severe. There's also a need to show there's a pattern of violations which are inhuman or degrading. So unpacking that, we sure have a pattern here, don't we? You know, don't we have a pattern? I mean, the pandemic has certainly shown that. The highest, almost 1 million people dead, the highest percentage of any country in the world because we don't have a decent healthcare system. So we have a pattern. And is it inhuman or degrading to not be able to have health care, to lose your life, to be permanently harmed because you couldn't get care in time? Yes, I think it is. And then there's the question of the violations being repeated. Well, yes, they're repeated and repeated. You know, the right to healthcare, we've been trying to claim this for some time, and we're still, asking for healthcare. So the rights are, it has to be human rights. Well, there's a lot of human rights that are, described in these treaties and declarations, and they surely include the rights to health and the right to life. But they also include like the right to be free from discrimination. And so that goes along with this healthcare system. So many of the examples we have, especially during the pandemic, are related to discrimination and unequal ability to get care and to be healthy. So next. So a little bit about the UN system and how this all fits together. So you just have a general perspective on this. So the council, the UN Human Rights Council, a part of the UN, is an intergovernmental organization and was created in 1945. And as I said, the US is the party to this charter. This is a treaty that the Senate ratified, and we have these component parts of the United Nations system, and one of those is called the Economic and Social Council, and that's a part of the General Assembly of the UN, which you could think of it kind of like it's not a parallel to Congress, but it's a legislative branch. To the extent that there's several legislative branches, but it's a legislative entity. And so that Economic and Social Council created earlier a Human Rights Commission, and now it's called the Human Rights Council, but that is an arm of this part of what's called ECOSOC, Economic and Social Council. And so you can see there's a little bureaucracy here, but bear with it. It's not too elaborate. And so the membership of the Human Rights Council is elected. it's elected by the whole General Assembly. So that's all the members of the United Nations, which I think are 198 countries, and maybe a couple of observer states. So the membership now of the Human Rights Council is 48 countries. And the United States is now part of the Human Rights Council, by the way. The headquarters of the UNHRC is in Geneva in Switzerland. So Mary was talking about the various meetings that she's been part of civil society groups, NGO groups from the US, going to Geneva to monitor these meetings and hearings of the UNHRC. So it has, besides these periodic reviews, which Mary and I worked on the last one for the Universal Periodic Review, which was in 2020, and we worked on the issue of the financing of healthcare. There's also this special complaint process for complaints of gross violations of human rights. And I've just mentioned that there was a human rights complaint filed in the early 50s by, and it was called We Charge Genocide. There was a petition. African Americans brought the killings of Black people in the US to the attention of the United Nations. And it didn't end up in any kind of successful response from the UN. And we can talk about that. But I think it was a really important historical development. And it gives us a little bit of historical perspective on the use by people in the US of this procedure, even though it hasn't been invoked by a US group since then. Next. So I'm just going to go through the mechanics of this so you understand what the process is. And, I think we can talk about what does it actually mean and how do you build a campaign around doing something like this? Because it is very specific and it's not necessarily everything that we want, to do in our movement, but it offers us a pathway to trying to hold the US accountable. And that's what this is all about, is using the human rights violations to try to hold the US accountable. So the first phase is the initial screening. So after the complaint is filed, it's reviewed by the secretariat. That's the staff of the Human Rights Council. And they have a working group on communications. So I guess that's called that because basically it's a communication from somebody to the Human Rights Council about gross violations of human rights. So it goes there first. And that chairperson of the communications group and the staff do this screening, and they look to see if the complaint is admissible. So it has to be admitted by them. So these are the criteria that they have for admissibility. And some of these are, people might find them humorous, but I just put them all down. It must be in writing. It has to be in an official UN language. There's 5 official languages, and one of them is English. It has to describe relevant facts. So, we're seeking stories, as we'll discuss further. It can't be more than 15 pages. So to me, as a lawyer, that means lots of footnotes and links. It can't be politically motivated. I interpret that to mean partisan, not because everything has a political dimension like this. So it's not, it can't be designed to get rid of your political enemies or whatever. It can't be based solely on mass media reports. So that suggests that you can have, obviously, research, scholarly research, economic research, health policy research, but like a bunch of news articles, for example, would not do it. So I think that's what we're talking about here. It can't be a matter addressed in separate proceedings of the United Nations or of a human rights intergovernmental organization. So that is really designed to keep people from filing, or organizations filing with a lot of different organizations. Like there's also an Inter-American Commission and Court of Human Rights. So somebody might file something there and with the UN. So they don't want to be one of many. You just have to go to them. Obviously, this is, you're not supposed to use insulting or abusive language. That's why I say some of this is humorous, you can't ask for individual remedies or compensation. So you're not asking for damages. What you're asking for is basically a remedy to fix the system. We're asking for systemic change. And the question of what we ask for is also something we should talk about. But I'll just mention that in our periodic review report, shadow report that we filed, the 4 organizations, two that Mary's connected to and 2 that I'm connected to for the 2020 review, we asked for a national publicly financed dialogue on single-payer financing and universal health care, as well as their recommendation that the U.S. adopt such a system. And that's not so crazy at all, because the UN Secretary General Ban Ki-moon back in 2016, I think, actually advised the U.S. to adopt a single-payer system.
Mm-hmm.
Anyway, so I don't really, but we will be figuring out what we're going to ask for in terms of a remedy. And of course, they would be looking at trying to convince the U.S. government to do what it's supposed to do. One other thing that is important to mention is we have to show that domestic remedies have to be exhausted. So that's it, or they're ineffective or unreasonably prolonged is the language. Well, what they see as exhaustion, in some countries they have human rights courts or constitutional courts that actually adjudicate human rights issues.
Yeah.
I realize this is very strange for a U.S. audience to hear, but that is in fact one of the situations that might exist in some other places. Also, a human rights institution, and I'll just mention that at this last review of the United States, when the Biden administration came back in the final response to us and the recommendations, they said they were never, or they didn't say never, but they said they were not planning and not going to establish any kind of human rights institution. So they made that really clear, and we'll be using that against them. Let's see. Then if these criteria are met and the complaint is admitted, it's sent to the U.S. government for its response. So that's the next step. Next. So then at phase 2, the complaint goes to, in the communications group, there's 5 members. And in 2022, the membership of this group is Spain, Russian Federation, China, Egypt, and Peru. And the president, or the coordinator for the group is the person from Spain. And there's 2 meetings this year. The 29th session, which actually got postponed, it's going to be in April, And then the other one got postponed. The 30th session is now going to be in October. So what we're trying to do is get our complaint filed by July so that we can be timely enough to be considered for the 30th session. The communication group reviews the complaint for its admissibility and for its merits. And so it has, and I'll talk about the merits, and then it can dismiss the complaint, keep it, or ask for more information, or send it to the next working group, which is called the Working Group on Situations. So the merits now are, this is when it gets really into the details. And the merits threshold is whether the complaint by itself or in combination with other complaints appears to reveal consistent pattern of gross and reliably attested violations of human rights and fundamental freedoms. So as I see that, you could even have multiple filings because they would look if the complaints are germane, if they're related to each other, they will be looking at them together, for example. But they will be looking at the consistent pattern of gross violations, and they're going to be wanting to make sure that the evidence shows that is when they say reliably attested, they want evidence. So that's the issue with that phase. Next. So the situations working group. So this is like looking into, beyond 2022, obviously, because by the time you get to this procedure, it's late in the year. Maybe probably 2023, but each year you have a different composition of these committees drawn from the Human Rights Council, and the work situations group is elected from different regions. So the regions that there are only 2 members right now. I think that the other, let's see, there's one is from Belgium, and the other is from Indonesia, and then so there's 3 other members to be designated. So who knows what the group will be for 2023, but in any event, that it's not really going to be related to getting the complaint to the first at the first level, which I think should be our focus here, is the communications working group. But just so that people understand what the process is, then this group, situations committee working group, does a report. They do a report and make recommendations to the full council. So they can either, suggest discontinuing the process, keeping it under review, getting more information, or sending it to the full Human Rights Council. So ideally, I think we'd like to keep this thing going, and have the full Human Rights Council. But practically, there are some issues because of U.S. imperialism and the economic power it has. The question of, how much we're actually going to get out of this is an open question. So happy to discuss that. But anyway, I think that, and again, the composition of these working groups, is interesting. I think the fact that Russia and China are on the committee is, it's probably bad timing given the war situation. But on the other hand, a lot of countries are afraid to criticize the U.S. You can see that in the periodic review process by some of the recommendations. So I think that, we want we want some people who are actually going to look at what we have to say. And we are so counter to the international trend that there's hope that other countries will say, hey, you just need to, this is not okay. So next slide. So if it went to the full Human Rights Council, they do have this confidential process. So they can either, and again, they can discontinue it, keep it under review, get more information, the same old. Appoint an independent expert to monitor and report back. That's kind of interesting because that's often done for situations that really require some additional information, or maybe because they're really controversial too. They can also make it, make the complaint public, make it and the report public. And then I think this number 5 is actually rather amusing when I think about how the U.S. wields power in the United Nations. They can recommend that the Office of the High Commissioner for Human Rights provide the U.S. with technical cooperation, capacity building, or advisory services. I'm not sure what that would look like because it seems like it's not really technical cooperation we need. Capacity building, maybe, and maybe advice, but it's kind of interesting and in some ways reflects the, the way the UN is used in some ways to shape the behavior of smaller, less powerful countries and not the powerful ones. But nonetheless, this is what's available to us. So this is what we intend to try and see what we can get. Thank you.
Yeah, absolutely. So we're going to start the Q&A session here, but I actually wanted to just kick it off with a question of my own, just for the audience's sake. If either of you can go ahead and take this question, I totally understand why the verbiage is important as we discuss these things, to use the word right. I'm curious if one of you can explain, though, like what right really actually from a legal framework means. It's a little bit different than, I like the takeout place up the street. I don't have a right to the takeout food at the place up the street. Can you just explain what a right really means in a fundamental sense?
Sure, I'll go for it, and Marty can add to it because I know she has a lot of background on this issue. But so a right is something that our government has an obligation to, this is legally, to honor for each person that has that right. And so when we're talking about the right to health and human rights, we're talking about every human being. So it's something that the government literally is required to honor and not interfere with, is the best summary. Marty probably has some more technical details she can add.
Yeah, and under international human rights law, that it's kind of broken into 3 components. Each right, there's a right to respect it, a right to protect it, and a right to fulfill it. So there's kind of different gradations of accountability on the part of the state. Obviously, if you have a right, you have a remedy. So that means you can sue the government if it denies your right. Like now, if we tried to, that's why one reason why, we could say we can't we can't exhaust any domestic remedies because we don't have any right? What are we going to do? Go file a lawsuit? You'd be, if you were a lawyer, might be disciplined for filing a frivolous claim. So it's, there's a lot of, there are arguable ways to raise it in U.S. courts, but not in a broad way like this because it's a systemic problem. But so anyway, you do have a remedy. remedy means you can get, some kind of legal relief. For example, if like just denial of care, say, you didn't have access to hospital, I mean, that person could file a lawsuit if you had a right, and for whatever damages, happened to them or their family if the person died, if you had a right to health care and you were denied access.
But I also think there's an important concept involved because so it's not just the legal remedies that are available, but when we are, for example, dealing with elections, if we can convince our electeds to talk about healthcare as a right instead of insurance, there's something in our minds that makes it more powerful. So I just wanted to throw that in.
Yeah, and actually, if you guys could just elaborate very quickly on why that rhetorical tool. I don't mean that to be demeaning at all. It's very important that we use the right language as we discuss these kind of things, right? I talk a lot about modern monetary theory, and one of our big things is using the right language about federal financing,
Right.
that this is about resources and not actually about the money.
Right.
So along those lines, can you talk about how important it is in terms of convincing the public of our position to use the right language?
I think it's crucial because when we're talking about or equating health insurance with health care in our own minds and in other people's minds, all that's really coming up is cost aspects, okay? They're not thinking about the quality of life issues. They're not thinking about human dignity. Whereas if they're calling it a right, that brings with it, in our country particularly, a certain concept. People are always, it's my right to do this and to do that. And whether or not I agree with them, if it's their right, it's their right, And so I think that gets us past some of the divide in terms of, we're not talking about the Affordable Care Act and whether to expand it. We're talking about treating healthcare as a right.
Mm-hmm.
I don't know if that's what you were asking for, but
what I would like to say is the reason I have laid out the principles that undergird the right to health care is exactly this question, because a right, the U.S. uses rights all the time, human rights, it weaponizes it. It's all about every other country except the United States, right?
Yep.
And
Yep.
Right, wrong. But the reason we bring out these specific principles that make up the legal standard, universal access, acceptable and dignified care, and so forth, the ones that I've laid out in my slides, is that those are the standards, not what the U.S. says, not what governmental spokespeople say or some misinformed person. So what is really important for people to actually take those elements and figure out how to use them in the work they're doing, and frame the work they're doing in terms of whether whatever is happening meets all of those standards, not one, because you're just going to pick one little thing. Like now with the ACO REACH, the latest scheme to deprive seniors of Medicare, they use equity. They've got, they love using equity and misusing equity it's going to be about denying care. And anyway, so what we have to do, and we have to be really savvy about those principles. We have to call them out when they use equity and they don't mean equity. They're just lying, and we have to show how they're misrepresented. Same thing with universal, and same thing, as I said, I tried to unpack a little the whole issue of affordable. What affordable means. It's affordable from the point of view of the individual, not this language that they used in the Patient Protection and Affordable Care Act. No, that's not affordable. Affordable means that you can enjoy your other rights. You don't have to give up your right to housing in order to have health care, or your right to an adequate standard of living. You never have to give up another human right to have your right to health care. That's a cornerstone of human rights analysis, and just the foundation of the legal project.
Absolutely. Yeah. And I'm reminded of an anecdote that Bernie said when he was confronted with the term access to healthcare. And he said, well, I have access to a private jet. Is there any guesses why I don't have one? And I think that's kind of a good way to put it. So I'm going to read a couple of questions here. I apologize for looking down, but I'm going to read these off my phone here. The first one is from Jonathan Cadman, who's one of our fantastic writers at Real Progressives. Just a quick shameless plug for those in the audience. Go to realprogressives.org if you want to read our fantastic content. Jonathan asks, with the fundamental governing principle of the UN and international law being the inalienability of sovereignty, how can any government be held accountable for their commitment to these rights, or even for taking them seriously? If either of you wants to go ahead and dive in on that.
Yes, well, that is the challenge. That is the UN system. It's an agglomeration of states, and the U.S., has pretty much been the most dominant state for a long time. But it still gives, what we're dealing with is the court of public opinion. We're dealing with trying to use this in our domestic work. And so that's another thing that I should stress, that we use this in the U.S. because the U.S. has the parts of the U.S. system who don't want to fulfill our human right to health care have evaded any kind of accountability. And we use this in all ways, at the local level, throughout the U.S. and in an international forum, to try to embarrass, shame, whatever we can get, by showing that the U.S. is totally inconsistent and just lying, So,
And the other thing is that when each of these sovereign nations joins the UN and enters into and signs on a declaration or whatever, they have, to a certain and limited extent, given up their right to say, I'm a sovereign nation, you can't say anything to me, by entering in to the UN process. So they, in other words, have to listen. Doesn't mean they have to do it, although there are remedies that for people getting censored and stuff like that. But yeah.
I see. Next question here. This is from Dan Gallagher, who was one of the organizers that put all this together. Huge thanks to Dan. He says, without strong advocates, family paid caretaker in our current for-profit healthcare system, patients' needs in many cases are either ignored or denied. Do you believe national improved Medicare for all would lessen the need for a patient advocate?
Oh, I definitely do. As I was saying, I think a lot of the problem. All right, so going back a while back, when a woman has a baby and the insurance company tells her that his expenses in the hospital aren't covered because he's not listed on her policy, even though they paid for maternity care, like that happens. So that's just sort of a crazy situation. And it's definitely something that this applies to. Marty, I'll let you go ahead too.
Well, yeah, this whole question, I think, of how the system actually functions, and I would just add, that it even now, even if you have an advocate, I'm not so sure that advocacy always works either. I've had my own experiences with with my father, end of life care, not being in pain because of the unwillingness to prescribe drugs to a person who's dying and having to advocate and feeling totally ineffective about that, because although I did it repeatedly, each time it was new, right? The cycle was not, because of the system was not recognizing the dignity of the person who chose, who would, or the family, really not recognizing the need to give comfort and ease pain. And although that might not be the best example, I think that the problem is really the profit motive in a lot of this, because the needs of the patients, which have to be advocated by the advocate, are often not what the profit-driven system wants to do. And so if you remove the profit incentive and profits, you can have at least a much better system. And I certainly saw that. I was in Cuba in November on a health delegation and saw the Cuban healthcare system. And I didn't hear any discussion, which is, a very fine system that really does meet human rights criteria in all ways. And I did not hear of any particular institutionalized advocacy system. My impression was that the system was built into the way the system functioned. But anyway, I do think that it has to do with the profit making.
Absolutely.
deviation.
Absolutely. And one thing that gets left out of Cuba is they pump out more doctors per capita than any other country in the world, by my knowledge. And a lot of those doctors end up in Doctors Without Borders and programs like these that actually help nations that might not otherwise have access to certain care. We have a question here from Stephen Katz asking, which instruments of international law has the U.S. agreed to that speak to the human right to healthcare, if any, I suppose?
Yes. So the Universal Declaration, the U.S. supported, and that's considered customary international law, even though it's not a treaty. But that includes the right to medical care in Article 25. And then the U.S. has signed the Covenant on Economic, Social, and Cultural Rights, which in Article 12 has the right to health care, but it has never ratified that treaty. However, the UN reviews the U.S. on the right to health care and health every single periodic review. And the U.S. responds with, to the recommendations, as it did this last time, by saying it didn't have to progressively realize the right to health care yet in the United States, that it doesn't need universal access yet. Let's see, that came into effect in 1967. So how many years is it since? Anyway, it's just absurd that we don't have, there hasn't been enough time elapsed for the U.S. to be held responsible. So the other treaty, International Covenant on Civil and Political Rights, has a right to life and right to non-discrimination. Those are also applicable to healthcare. The U.S. has ratified those, although with reservations, and it always reserves. One thing I should tell you about how the U.S. deals with treaties is it always claims that it doesn't have to do anything in addition to whatever exists, that it doesn't have to change anything. So it won't ratify a treaty unless the existing domestic law already requires it to do that, which might be why the U.S. is the only country in the world that hasn't ratified the Convention on the Rights of the Child, which also has the right to health care. But those are
They'll sign them, but not ratify them, right, Marty?
Yeah, well, some of them they haven't even signed. And then, the Senate actually rejected ratification of the Convention on the Rights of People, persons with disabilities.
Yeah.
And that's more recent. But Yeah, I mean, this is another whole area of work, but I could go into it more because I've been involved with the Children's Rights Convention and getting a resolution in Washington State, but it's very difficult. So I think we just bypass the treaty issue here by saying that the right to health care is a customary law right. And the U.S. has to comply with customary international law. You're muted.
You're muted, Luke.
Thank you. I wanted to ask you both. I know this is a topic that's kind of been a main theme here over the last couple of hours, but I'm really fascinated by sort of the way that a lot of the language is co-opted by those who get to profit off of the system. And I'm curious if either of you have some advice for the audience on how to recognize that language and digest it in the right kind of way, I suppose you could say.
I guess what I would say is that when you hear a word like that, and I hate when I see a television ad by an insurance company and they use a word that they're co-opting from our movement, correct? And it's very difficult because, I mean, I recognize it, but a lot of people wouldn't recognize it, which is one of the reasons, again, going back to calling healthcare a right, that I think then we can emphasize to everybody what equity really means, okay? Not what they're saying it means, and what public good really means. So, other than sort of maybe putting out talking points about, did you know that pharmaceutical companies are co-opting our language, blah, 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 with talking points on it. It's something I've been struggling with for a lot of years. So it's a very good question. I'm sorry I don't have a better answer.
And for me, I think that this is why I think it's important to go beyond the word human rights to actually look at what the principles are, because if you look at the principles and compare them to what is being said, you can actually bring them, you can actually take them apart. So like with affordable, for example, and people can just say, this is not affordable. This is, it's a fraud. It's a fraud. I think also that it is hard because it's just amazing how much human rights and democracy, all these, these words are misused, right? I mean, the people in power understand the value of using that. But so I do think you have to delve deeper. And that's why, I really feel strongly about just nailing down what those principles are so that people can actually do that themselves, because it's accessible, that information, and can be used, and people can they could do their own work, with that principle and look at what's happening in their own, neighborhood or whatever, or to them or to other people, and explain how it is. For example, this is not affordable, and put the data together themselves. I mean, people know what's going on.
Absolutely. Well, hey, I want to thank both of you so much for taking the time to do this panel. I think this was a fantastic discussion. I do want to briefly plug, I was supposed to do this earlier. I apologize. Anyone interested in getting involved with this complaint to the UN, M for All at m4mforall.org. And the 4s are the number 4. M for All at m4mforall.org. And if you have a story you'd like to share, you can share it at stories@m4mforall.org. Want to make sure to plug that. And I also do want to thank, once again, our sponsors for this summit, M for All, obviously the March Group, National Single Payer, Real Progressives, Yellow Vest Actions, and Indie Left Media. Thanks to everybody who's worked behind the scenes to put this on. And with that, I will thank Marty and Mary so much for taking the time. This was a fantastic panel. I appreciate you both being here.
Thank you.
And thank you, Luke, and thank you to everybody who's joining our cause.
Indeed.
Absolutely. Yes, absolutely.
Onward.
Yeah, yep.